Dr. Mayfong Mesai, the floor is yours.
A very good morning. Sawadee krab. The AAAH colleagues, Ministry of Health delegates, experts from member countries, members of the academia, international development agencies, private sector, human resource for health advocates, ladies and gentlemen. As the chairperson of the Asia Pacific Action Alliance on Human Resource for Health, or AAAH, and steering committee, I have the honor of welcoming you to the pre-conference meeting in collaboration with the prestigious PMAC 2024. We are gathering here to focus on a critical issue facing our region: strengthening local health system in Asia Pacific nations to address the impact of international migration of health workforce. In this dynamic healthcare landscape, healthcare workforce migration has emerged as a prominent and complex issue. This phenomenon refers to the movement of healthcare professionals, including doctors, nurses, pharmacists, and other allied health workers across borders within Asia Pacific region and beyond. Health workforce migration can exacerbate health inequities within and between countries. Source countries, particularly in rural areas, often face a shortage of healthcare providers, resulting in a limited access to quality healthcare services. To tackle these issues, the management of healthcare workforce migrations requires coordinated efforts at the regional, national, and international levels. Policies that balance the needs of both source and destination countries are very essential, as well as collaboration to ensure ethical recruitment practices and workforce planning. In addition, it is essential to protect and listen to the health workforce regarding their quality of life and fairness in rights when they migrate. As one and the only regional networking in human resource for health since the year 2005, the Asia Pacific Action Alliance on Human Resources for Health, or AAAH, was launched. Since the day it launched with 10 founding member countries, the membership has gradually expanded to 22 countries, encompassing 10 from Southeast Asia region, 9 from Western Pacific region, and another 3 from the Eastern Mediterranean region as of 2024. The meeting aims to strengthen local health systems in response to the international migration in the Asia Pacific region. It also provides a platform to share unique regional needs, challenges, and initiatives to address the power disparity resulting from decolonization with the overarching goal of collective support from global organizations. Moreover, this forum is designed to foster effective intra-regional and inter-regional collaborations, aiming to enhance our collective capacity in managing the mobility of health workforce with greater efficiency. To conclude, I would like to express my sincere thanks to the AAAH Secretariat and also the AAAH Committee, partner organizations, especially WHO, SEARO, and all the stakeholders and experts from 22 member countries, as well as those from other nations. Your unwavering dedication, commitment, and enthusiasm are the driving force behind our collective pursuit of strengthening HRS and enhancing health system resilience. I do hope that this meeting will bring about mutual collaboration, constructive and creative action, while at this same time, it would allow us to reflect on the situation of health workforce both at the national and regional level, thus ensuring that the coming years will be the best case scenario for healthcare workers and for everyone. Thank you very much for your attention. ขอบคุณครับ
I would like to invite our staff, the team who made it all happen, someone who I met, even if we're from Thailand, in Berlin, Germany. So Dr.Chawisar Janekrongtham will be introducing you to this session.
Good morning, everyone again. My name is Chawisar Janekrongtham, and it's a very honor to be serving as the Secretariat Manager of AAAH Network. Yeah, which you already know that it's only one regional network in these regions, and like long-standing since 2005, right? Yeah, before we have an opening remark from Dr. Mayfong, I might go first. Okay, and then I just want to have your 10 minutes in order to talk about, to guide you in our day. So the objective of today, I would like to guide you focus towards the core objective that defines our journey. And we have been the only regional network, right? So first, we aim to strengthen local health system. The secondly is we will focus on sharing unique regional needs and initiative to garner global support. And thirdly, our goal is to enhance intra-regional and inter-regional collaborations for better management of health workforce mobilities. Here is to achieve our objective. It's essential to understand the diverse mix of expertise we have in this room. Each of you bring unique insight, making this gathering is a ground for collaboration. And among 50 participants, but now we have more, actually, from 17 countries, but I think now maybe 18, we have Cuba as well. We got a good mix of sex, 91% from low-middle income country, and majority from country in SEAROs and WEPO regions. Apart from Thailand, the Philippines, Laos, Indonesia, Japan, Nepal, and India are dominated. Here, 70% of us are from national agency, while 30% from international. We have various organizations here. Majority are from Ministry of Health. We also have unions to represent our workforce voices, including unique global unions. We have a union of professional health workers from Nepal, as well as we have a migrant health workforce and youth federations. Nursing council we have from Thailand and Jordan. Think tank organizations such as Access Health International and HPP. You have university here and international agencies such as WHO, JICA, USAID, ADB, IOM, and UN. Here comes to our intention for today. This is the week guide with the full concept, align well with our objective. As we proceed our conference, let's keep this concept in the forefront of your mind to drive our discussion and actions. So the first is about cross-collaboration. This is the heart of our agenda, and we aim to bridge gap and build network that transcends border. Second is a win-win-win scenario. It's what we are striving for. Our goal is to craft policies and strategy where source country, destination country, and the migrant workforce all emerge stronger. And the third is decolonize policies. We seek to advocate for policies and unique needs where ensuring that country voices have to be heard. Lastly, the smart investment in our health system and workforce is imperative. It should also be investing in capacity building, right? And ethical governance and sustainable practice. For this picture is the migration cycle that we use as a framework. As you can see over there in the pictures, is the migration cycle. It is developed under the EU project, strengthening the development potential of EU mobility partnership in Georgia. And this is a pioneering effort to match the labor needs and the triple win outcome. Come back to our board that there. It is designed for you to share your idea. In case you have any idea come up during the conference, please don't discard any post-it. You can write it down in the post-it, and then please help us filling in the gaps by placing your post-it in any of the stage of the migration. That would be very grateful for us. And for the entire migration cycle, this is include before, during, and after migration process. And here we highlight the skill, qualification, visa and work permits before the migration stage. And during migration, we highlight maximum potential position to prevent the brain waste. And the job allow the individual to work their highest potentials in every single country that they goes. And we want to talk about like housing, community engagement, and potential brain gains when they are living abroad. And after the migration stage, we highlight on recognitions of qualification as well. Okay, for the next step, here, it's just before we dive into agenda, which Mancharee already briefed. Let's talk about how we can make today not just productive, but also enjoyable. First, here come to like the friendly do's that I want to share. First, come charge up. So be ready to save the day with your ideas. And second, jump in, hear your thought, ask questions, sharing, ask questions, and also get less lively discussion going on. The third thing is listen attentively. Let's use it to truly understand and appreciate each other's point of view. And lastly, stay on topic. This will help to ensure all important points are covered. Okay, so the agenda, here come with the agenda. So let me summarize. For the morning, we're going to diving into the theme of challenge and collaboration. We will kick off the inspiring session from our panelists, while we won't have space for Q&A session. Don't let your brilliant idea to slip away, so jot them down. After you have any point that you want to discuss, put it in the post-it notes and be ready to spark some lively discussion during the break and during the roundtable discussion. And moving to the afternoon session, we are thrilled to have Dr. Johanna Bassen to share her insight on collaborative and data-driven approach. Since the topic is the fundamental in the era of workforce mobility, following the Dr. Bassen talk, we will engage with another round of panel discussion and roundtables. And this time, we will focus on innovations and smart investments, and it's the opportunity to explore strategic approach in our field. And after the break, Bo will facilitate the session, very interesting session. I want you to be until that session. It's the matching market. This is a unique opportunity for all of us to connect and engage in the meaningful conversation, and that could spark new initiative and projects. And lastly, we will end the day with a section of agreeing on the next step. As I am ended, I would like to thank you, all the main organizers here today. And I would like to thank you, our main funder, the WHO SEAROs, and moderator, Manch and Bo. Thank you so much.
Thank you very much, Dr. Mayfong, for your very important opening remark. Next, let's move on to our second sessions. I would like to call in three names who are very important, and this session wouldn't be able to happen without these three contributors. First, including Gulin Gedik from EMRO, Ibadat Dhillon from SEARO, and also Masahiro Zakoji from WPRO. All these other representatives from our partners. So if you are ready, you are welcome to the front of the stage.
Good morning again, and I hope you don't mind I speak while I stand so that I can see the screen as well. My name is Masahiro from Western Pacific Regional Office of WHO. I don't think it requires any explanation that this is a topic of interest of many different stakeholders across the region and globally. You will see all the news articles every day from different countries, from different angles, let's say in the Pacific, there are many small island countries that are suffering from a massive number of healthcare workers in comparison to the total size of the stock in those countries. When you look at the number of those healthcare workers migrating to larger countries, so I don't pinpoint particular countries, the proportion is not large. In those countries, that can only make up 1%, 2% of the total healthcare workforce. But if you look from these sending countries' perspective, it's 20%, 30% of the total healthcare workforce stock. So that's really the standpoint that I want to start with for this session. If noting all the challenges of the data availability, and I would say today it's really a luxury for us to have all the expertise and intelligence from the frontrunners from countries, because we do not have the complete picture of these very complicated issues. And of course, there are instruments called National Health Workforce Accounts, which WHO work as a secretariat for member states for you to organize health workforce data and report to the global platform. But still, we do not have all the information that we wish to have. Currently, based on the available 133 countries information, it looks like 2.7 million healthcare workers are actually migrating, but we don't think this represents the entire picture, and this is still an underestimate to a great extent. And 60% of those numbers are nurses and 30% are medical doctors, but it doesn't necessarily mean that those are the only ones, again, because those are the ones that we tend to have better data when it comes to data availability. So those are the limitations. And if you look at each occupations like doctors, nurses, dentists, pharmacists, those are the proportion among those occupations in each country, how much of those occupations are actually from foreign trained. So this is a very basic general picture of the global health worker migration, but still we like to note the limitation that we mentioned. And this is the global report that is published last year, July. So we believe this is one of the latest one that collate all the information that countries have put forward. If you look at the color of the countries in the map, the greener, the more occupations countries are able to identify the health workforce migration data and report. You may have some objections to the status because this indicates the 2022 data set, and this is a live evolving data set. So as soon as your country focal point for national health workforce accounts update the information, those are updated at a rolling basis. But you may wish to have a quick look at those global reports that have been published based on whatever your authority has put forward. Apologies that the fonts may not be large enough, but WHO regions were categorized into 6 groups as briefly introduced, and AAAH members countries are coming from 3 regions, and one is the Southeast Asia region, and the other is East Mediterranean, and the last is Western Pacific. As you can see, the proportion of the foreign-trained medical doctors and nurses, the trend is quite diverse, and it's really difficult to generalize the trend. You can see all the outliers of the dots up to the top of each medical. So, for instance, in the Western Pacific region, there are some countries that says 100% of the medical doctors are actually foreign trained because they do not have any medical training institutions in country. So that's that challenge that we want to capture the regional trend of those migration issues. But still, one thing that we can mention here is that in general terms, the proportion of the foreign-trained health professionals are higher for medical doctors compared to nurses. So that's that may be natural for your understanding as well, but that's something that we can at least say. And if you look at the EMRO region, Eastern Mediterranean region, as you can see, the median for both doctors and nurses are quite high, which generally indicates that they are more dependent on migrant healthcare workers, but still we do not have the full coverage. If you look at the number of the countries reporting those data, let's say for Western Pacific, we only have 9 countries reporting on medical doctors out of 27, which means the coverage is just 1/3 of all the countries that we have in the region. We do not want to go into the details, and all the information that are publicly available, published, and this comes from the OECD latest publication, the healthcare worker migration. And the only message that we want to share here is that, of course, from the destination country perspective from OECD countries, it's clear that the Asia-Pacific countries are, of course, major source country for those, and we really need to indicate that this is an issue of concern, and also there is a potential for collaboration, regional collaboration among those member countries. And the right chart indicates the recent trend for the number of the UK registered nurses, midwives, based on the location training, and as you can see, the basic trend, not from within the European region, but from the Asian Pacific as a general trend. I think this is going to be the last slide for me, and I hand over to the code of practice expert, Dhillon. But this is just a general picture of the health labor market, and to highlight some of the typical failure points for those migration and health labor market. And of course, we are talking about the attrition and migration as a key focus, but also this is an interlinked labor market according to the working conditions or the local production capacity. Those has to be put together in a comprehensive way when we discuss the migration matters. That's my key message to conclude my short introduction to the regional and global overview to a good extent, or hopefully. Thank you. Ibadat.
Thank you, Masahiro. Just some quick history on an instrument that WHO has, which is the WHO Global Code of Practice on the international recruitment of health personnel. It was adopted in 2010. It was adopted after 6 years of discussion kept coming up at the assembly. We have Dr. Viroj, who actually chaired the adoption of this instrument. So it was an important instrument where ministries of health put their foot central stage on this issue. This is an issue that was often not felt reserved for ministries of health, but they put their foot there. So this was a really important document, and the idea was to have greater mutuality of benefit, just in a short way, short thinking, and to think about the impact on the countries, the source countries. That was perhaps very simply putting the code. The code then has a 3-year cycle of reporting on the code, and then importantly, let's see, in 2020, there was a 10-year review of the code. It was an expert group formed with member state representatives. Dr. Untung from Indonesia co-chaired the expert advisory group, and Dr. Rupa is here, was also on that expert advisory group. So they were looking at how to keep the code relevant at this point. We'll come to the health workforce support and safeguard lists that were developed. And now we're going into the 5th round of reporting on the code. And also in 2024, they will start at WHO headquarters. They will institute a 3rd review of the code's relevance and effectiveness. Especially this third expert advisory group will come on the back of the pandemic and in light of the pandemic. During the pandemic, I think we all became very aware of the lack of sharing of vaccine. So since then, we have seen that there was really a questioning of this international solidarity, international collaboration. Less prominent was the lack of sharing of health workforce. Across OECD countries, there was a very strong move to ease flexibilities, to allow flexibilities to quickly enable foreign-trained health workers to enter the country and support the COVID response. So, for example, there was a very significant concerns raised to WHO, especially around ICU nurses, anesthesiologists, so very specific recruitment of very specific groups to support the pandemic. In countries for Southeast Asia region, for example, other flexibilities were put in place when retired people or non-physicians were given more rights to address the COVID pandemic. So in general, there was a concern that this mutuality of benefit, solidarity was not expressing itself. So this is one of the reasons for the 3rd review of code. And I think we saw the figures that Masahiro put up, where now India, Philippines, and the UK are becoming significantly more important to them than from other EU countries. In 2023, WHO again updated this health workforce support and safeguard list. Fundamentally, they're looking at the bottom quartile countries that have difficulty in providing UHC service coverage and low density of doctors, nurses, and midwives. And based on this, there's really a strong message from WHO for all countries to really look at to see these countries as having severe health workforce vulnerabilities and to prioritize these countries for health personnel development and provide them with some sort of safeguard for international recruitment so that the recruitment should at least take into account the domestic labor supply, encourage the ministries of health to engage in the negotiations. This is difficult, but Dr. Bhim may know, but because of this one little provision, it allowed Nepal to at least have some say in the agreement with the UK that was negotiated, and try to get to some health system benefit to source countries. But the principles should be relevant to other low and middle income countries. So from our 3 regions, these are the countries that are on the support and safeguard list. In Southeast Asia region, I can speak to. There are 3 countries on that list: Bangladesh, Nepal, and Timor-Leste. Now we have a macro picture, but at the local level, I am almost certain Bangladesh does not want to be on the list. It is keen on sending its people out. Timor-Leste, actually, somebody said there's somebody from Cuba. Timor-Leste actually depends a lot on people coming into the country, especially the Cuban doctors, so it does not have a serious issue. Other countries have at least raised a different issue. Bhutan, maybe Sri Lanka, and the current vulnerability, even though they don't have a shortage, the way it is said, the vulnerability is present. So the principles of this list is still relevant to these countries. WHO will shortly come out with a guidance on bilateral agreements. Again, really highlighting the importance of these agreements to health workforce sustainability, to UHC, to health security, highlighting that the partnerships really should be focused on strengthening health systems in both countries. I'll come back to this. And also that the agreement should be monitored and operationalized and reported. Oftentimes we see them on paper. So this is very, very shortly, I think I just want to wrap up this beginning part. We'll have much more detailed discussion. It's really difficult to speak about international health worker migration without speaking about the broader context. So we are discussing in this conference polycrises, economic, environmental, humanitarian, societal, geopolitical fragmentation. One other item not there is technological. I work with somebody called Dr. Maymax, and he told me that the difference between our children and their expectations and our parents, so difference is greater with our children than with our parents. So the expectations of young people are very different today than the expectations in the past. And this is something that we should also be thinking about. Our colleagues in Maldives, for example, they started thinking about remote working for health workers, recognizing that a lot of administrative duties, follow-up could be done on phone. So really trying to think about how do you meet the expectation of these workers who may have different expectations. The opportunities, I think we are speaking a lot about decolonization. Another discussion that's happening a lot, especially in India, is around how the globalization 1.0 was very much linked to the old previous supply chains that were put in place in the colonial period. So for example, all of us will know about the Royal Colleges and the connections to London School and Johns Hopkins and but maybe not so much about connections to Chulalongkorn University or Gajah University. So really there's an opportunity to think about of globalization 2.0 where we connect much more with each other in the Asia Pacific. And as somebody said, to really capture so many local innovations happening that we can maximize. Then also decolonization in the light of rising importance of Asia Pacific. In my region, the Indian economy is now bigger than the UK economy. Indonesia's economy is now bigger than the Dutch economy. So really important to start taking that back. We had a quick discussion across our three regions. My colleague Gulin our colleague Gulin couldn't be here today. From her, a very clear message, time for action. Really that so many policies and strategies, but especially the Eastern Mediterranean, a lot of humanitarian challenges are happening. We have a colleague from Jordan, but really we need to have thinking of action. WIPRO has a new regional framework. Very focused attention needed in WIPRO on the small islands in the region. How do we support them? In SEARO, we have mixed picture, mixed countries, big and small. But really, the countries where the education is provided publicly and the service provision is provided publicly are especially affected and need to be carefully monitored and protected there. Oops. And some final reflections on the way forward. I think this is just to start our discussion. WHO right now, just this week, is discussing at our executive board the WHO findings from the WHO Commission on economics of health for all. And perhaps the main finding in that commission is that we have all long, maybe last decade, 2 decades, we have said health is a key driver for economic growth. And now they really want us to think differently and say, really, what is the point of an economy if it is not producing health? So the health has to be a goal in itself. It cannot be a means to something else. And I think that's important because especially on this subject, which is so difficult, there are many interests. There's economic interests, employment interests, education interests, trade interest, international relation interest, and health interest. and often the health interest is the last. So this really highlights that we have to bring that health as its own goal, as a very high level, invest in health systems. Health ministries take leadership in this area. I can give you two examples. The UK, it is the Department of Health that is leading discussion on international recruitment, and they use the code to take the leadership from other related ministries. In Indonesia, they at least strategically use the code to get into discussion on trade agreements with Japan, to be at least be on the table. So this is important. I think this really trying to look at cooperation between health ministries is fundamental. So not framing it as a labor agreement or a trade agreement but really if it can be a health cooperation agreement where there's truly equal stakes, equal partnership, so much there. I think the fifth round of code reporting, exchanging information, advocating together. Another big issue is engaging diaspora. Our systems, I don't know if you saw the SEARO slide. Other than a few countries, most of it is very, very small reliance on foreign trained workers. Allowing our systems to enable entry for foreign educated workers. What is the system? How do we bring them in? Can we bring them into the civil service? Can we bring them as contractors? Some system. And then transformative education, aligning our education systems for public purpose. So the regulating the health professionals, Indonesia later can speak to just how the health professional regulation, both in Indonesia and India, are allowing very, very significant increase in supply. Maximizing the workforce we have, which is not just the doctors, nurses, midwives, but we have all these mid-level workers that we can use more effectively. And educating for local needs. I think Thailand really stands out that it trains in local language. In India, almost all the education is done in English. So what do we, from doctors to all the way down to auxiliary people. So that is something to think about. But that's over, I think, from our side, Masahiro. So that is just to get us thinking and discussing. Thank you.
Thank you so much. I believe the both remarks that we could get from both WPRO and SEARO is that healthcare workers all possess unique skills and qualities before they embark on their journey. So how can we all here help preserve and enhance them as they move forward? And last but not least is that the time has come for a shift in perspective. Instead of focusing solely on brain gain or brain drain, maybe it's time for us to understand the concept of brain sharing. And here comes the time for the first panel discussion. I would like to invite this beautiful lady here, traveled from China, to be with us today. So Xu Fang will be with us and moderating the first panel discussion. Fang, the floor is yours.
Okay, good morning, everyone. I think it's the right timing to hear from a person who have their own experience about migration, on the policy challenges in health workforce migration beyond borders. Our speaker will bring diverse perspectives and inspire us to discuss further. Okay, without further ado, let's begin. Our first speaker is Mrs. Mancharee, please. A doctor of pharmacy from Cancun University and the chairperson of the Asia Pacific Regional Office of the International Pharmaceutical Students Federation. As Mancharee is married to a Norwegian citizen who is a doctor-dentist, she finds herself in a unique position where her family must make decisions to migrate, and regardless of the path chosen. There are both losses and gains involved. With extensive experience in both domestic and international settings, her insights resonate well with our focus. And then, moving on, we have our Dr.Hani Nawafleh. Yeah, please. The Professor of Community Health Nursing and the Secretary General of the Jordanian Nursing Council, holds a distinguished background that spans academia, legislative service, and leadership roles. As a former member of Jordanian House of Parliament and Dean of Nursing, his experience could provide valuable insights into the regulatory landscape of Jordan. Lastly, we have Dr. Noriko Tsukada. Please. Yeah, a professor at Nihon University College of Commerce in Japan, specializing in humanities and social science, with a focus on social welfare and social gerontology. She has actively contributed to advocating for the human rights for the elderly population and exploring the dynamics of foreign care workers. She is the one who helped to make it possible to hire migrant workers officially to support Japanese health system, which is the leading of aging society in the world. Okay, Mrs. Mancharee, the floor is yours.
Thank you so much. We are starting now, I believe, officially in introducing myself. At first, I was saying that my name is Maymax Sanngmueang. I actually prevented my husband's last name to keep the secret. Now it's been reviewed. So I'm actually the healthcare workforce who will be migrating myself, and especially the burden on my weight is not just how could I secure my future, it's also how could I secure my husband's future. Because he's not just a doctor, he's also a dentist in one person. So, no matter which decision I make, it's going to affect either countries no matter what. If I bring him here, Norway will lose a really good, health workforce, and how could I do that to the patients because he's so kind, and then also it's well known that Norway is also lacking of people or health practitioners themselves. However, they make it hard. I experienced it firsthand. When it was mentioned that Thailand is also practiced in Thai, unfortunately in Norway, 90% of people can speak English, but they also practice in Norwegian. So the first time I went to Norway, they said it's the most welcoming countries in the world. And I thought that was true until the minute you arrive at their doors and you don't even say hi in their language, and they said, come back until you are fluent. When I'm talking about fluencies, it's not about just saying hi, ordering food. They want me to be able to discuss policy, laws, and everything. And I spent 10 seconds falling in love. I probably have to spend 10 years learning the language. And you know that we all choose health or, these kind of profession for reasons. Maybe language is not our skills. And learning the 5th language in my life sounds like a burden. But again, the power of love make me move forward, and I believe at the moment I'm graduating from pharmacy school, but my future is so bright here in Thailand, but it's so dark in Norway, and I don't know where to go yet. So that's a brief information from me, and I would like to share with you, since both of you have been key players in terms of supporting people moving in and out, and how could we move forward. So Phang, should I pass the, yes, thank you.
Thank you, and have a good day. Good morning, everyone. It's really my pleasure to be with the great people with a great experience from all over the world. It's really a rich meeting and rich information. I'm hope we will get by the end of the 2 days. I represent Jordan. Jordan, as you know, it's in the Middle East. It's in the heart of the Arab world. It's located between Asia and Africa. Actually, Jordan is in a hot area. We are bordering Palestine, Israel, and you know the conflict, what is happening nowadays in Gaza Strip. Also in the northern part of Jordan is Syria. It's another also hot area. On the east area is Iraq. Also, it's a hot area. So you just imagine all this combination, and it's reflect on the country. I will talk about it on once my turn of speech. But regarding to my experience, after I got my bachelor degree, I start to work overseas as immigrant nurse. So I work in state of Qatar for about 4 years. Then after that, I went to Baghdad in Iraq. I got my master's degree. After that, I worked for a couple of years at the university as a lecturer. Then I traveled to Melbourne, to Australia. 5 years I got my PhD. Then back to Jordan. 2 years academician. Then I resigned. I went to the election, parliament election. I became member of parliament. So it's another story. Really, it's another story. It's rich of challenges. It's rich experience to be a politician. From academician to politician, it's another story, honestly. You learn and you gain experience and information more than the PhD I got. After that 2 years, then I get out from the parliament because the parliament is 4 years, actually, but we just stay 2 years. That time we got youth parties and we were very strong. Then we get out from the parliament. All the parliament waved. And the king asked for another election. After that, I back to the academia. I become a dean for nursing and health science. I went at that time also for Saudi Arabia as consultant for 2 years, then back. Then now I'm the Secretary General of the Jordanian Nursing Council, which is shared by Her Royal Highness Princess Mona Al Hussein, the mom of His Majesty King Abdullah. Also, it's another rich and challenging experience to deal with a person with a high level at the hierarchy, Her Royal Highness. It's really a new experience. But to be honest, it's a very flavor experience because you learn from those people how to deal, how to communicate, the humanity, the dignity, all these things. And I'm still working to support the nurses and the healthcare workers in Jordan and overseas, since we are a member in many committees at the Arab Board for Nursing and Health Science. This is all my short stories. Thank you.
Okay. Thank you for inviting me. I'm Noriko, a professor of Nihon University College of Commerce. I am a US-trained social gerontologist, but it's like 30 years ago, so I forgot English. So she speaks 5 languages, and I speak only 1 language and a small amount of English. So you need to be patient when I'm making a speech. Anyway, when I learned social gerontology at Miami University in Oxford, Ohio, I learned very beginning that all aging countries face 3 major issues, including social security issues and employment of older people and the workforce shortage, especially nursing care workers. That's how I started doing research for myself after I went back to Japan. And it's been like 20 years since I started this research. But my research area has 2 folds: nursing care, fully nursing care workers, as well as elder abuse. So I will be talking about nursing care workers in Japan. As you already know, the blue parts, longest life expectancy with low fertility rates. But I want to mention the social characteristics too. Gender gap index is really low. It's been really low. And only 9% of the households are 3-generation households. That means it used to be more than 50% of the household, 3-generation households. So we are really becoming to, we are losing ability to take care of family members by family members. And I want to say that we have a public long-term care insurance program, and also, of course, we have a health care insurance, but it's a public social insurance program, which has a universal coverage. This comes to today's topic. The population pyramid is like this, and it is going to be like this. And unless we have an immigration policy, which we don't have now, our population is shrinking and shrinking and shrinking forever. Okay, so I'm going to talk about healthcare workforce, today's topic. According to the Ministry of Health, Labor and Welfare, we have a gap between demands and supply in 2040. How many do you think? 960,000. We will be in short, okay? And so the government is, of course, taking measures to secure the gap. For example, doctors, there will be supply and demand equilibrium in 2029, which is good news. However, there are some challenges, for example, uneven distribution by region and by specialty. For nurse staff, the number is also increasing by new training, turnover prevention, and reinstatement support. However, they also have the similar problems, uneven distribution. And regarding to nursing care staff, which is the main topic today for me, a turnover rate has been decreasing, which is the good news. Good news by continuous improvement of treatment. However, active job openings to applicants ratio is not that good. Okay, this graph shows active job openings to applicants ratio. As you can see, nursing care staff is the marks the highest. So I am going to talk about this. So applicant, there is one applicant, there are so many job offers. That's how we see this number. Okay, then going to the second overview of accepting foreign healthcare workforce, status of residence regarding foreign workers briefly. We have 29 status of residence in Japan, and out of 29, 5 are related to healthcare workforce for foreign workers. And please take a look at number 10, medical services. This status of residence for doctors, dentists, and nurses, and pharmacists, etc., that requires for national qualifications. And in other words, this status was established in 1989. That means these professions, jobs are considered to be highly skilled professionals. So how about nursing care workers? It's only recent because we used to take care of, my family member used to take care of our older parents. So they were not considered to be highly professionals. However, EPA nursing care workers and we started to accept EPA nursing care workers in 2008. So we need to have the status of residence. We used designated activities. And later, very late, 2017, nursing care we created. And also we added nursing care status of residence. We added to the already existing status of residence technical intern training program, which started in 1993. And only recent, like 3 years ago, we created another status of residence, specified skilled worker. Okay. So, coming to programs for accepting foreign nursing care workers, workforce. Okay, we have 4 status of residence to accept foreign nursing care workers that I mentioned. The purpose is totally different each other. The first one was to strengthen economic partnership relationship between the 2 countries. We have agreed upon with 3 countries, including Indonesia, Philippines, and Vietnam. And the second one, nursing care, this one means that we accept students, and they go to universities or vocational schools and learn nursing care skills and knowledges and take the exam. And once they pass the exam, then they use this status of residence. So that allows foreigners to work as nursing care workers. And the technical intern training program, the purpose is, underlined, the purpose is for technology transfer. And the last one, specified skilled worker, the purpose is to secure workforce shortages in 14 job categories, including nursing care. The Japanese government finally admitted that, okay, we are in short of workforce, finally. They said that, admitted that. Okay, how do they, are they located? This shows the levels of skills required for status of residence. When you please look at this one, technical intern training, very unskilled and technical areas. They are at the bottom. And EPA and nursing care workers, the upper. And this specified skilled care worker, they are in between. Okay, this table shows pass rates of national qualification exam for EPA certified care worker candidates. They started about 38% of pass rates, and now more than 70%. So they have been doing a great job. For the nurse candidates, they started from 0, and now they marked more than 20. I read the article, said for them to pass the exam, for nurse exam, it's at least they have to have the Japanese language proficiency test #1, which is the highest. So I think there is language barriers. But they are doing great. I don't think I can do that for other languages, in other languages. Okay, I need to mention one thing. There is a discussion, but there has been discussions. Technical intern training program. This program has been pointed out that there are so many problem issues that needs to be solved. The biggest one, I have to say, and I have to admit, that violation of fundamental human rights of trainees. They have no pay, longer work hours, and fake documents, and safe working environment that all we need to be ashamed of. And trainees cannot change their workplace, and there are brokers issues. But I think the red part, the one is the most critical issue. However, there is a good news. Finally, government started to re-examine these issues of the program. And last year, the final report, last month, final report was issued, and they are starting to develop a new program to create continuity between technical intern training program and specified skilled worker for the purpose of securing and developing human resources. So they set 2 goals. Okay. So future challenges will have to be real quick. What needs to be done? Okay, we have 4 status of residence, right? However, how many really are there in Japan now? According to the ministry, we have this many. So if you add up this, we have only like 40 something, right? So don't you think it's a small amount? Okay, this slide shows trends in proportion of foreign workers to the total working population. Japan is here, and which is really low of 2.3%. So it's not surprising to say that migrant integration policy index is really a low ranking. What needs to be done? Yes, the Japanese government trying to secure the healthcare workforce, especially nursing care workforce. They set 3 goals: call back displaced care workers, and increase new entries, including students and citizens, and increase retention rates of nursing care workers. But I think this is the most important thing. Working conditions, images of nursing care jobs must be improved, Please take a look at the blue circle. We have so many latent certified care workers, right? About 20% of the qualified workers. That means they have qualification, but they are not working in the long-term care setting. I think that's a problem. So we have to attract these people. Otherwise, foreign nursing care workers also leave such jobs that Japanese people are not attracted by. Right. Why? Because we are the same people. Right. So I want to add one, now it's too late. Okay, I think that we need to develop a career ladder for foreign nursing care workers and also develop social integration policies, which is far behind. And we need to develop social security agreements among 3 countries, EPA 3 countries, 3 EPA countries, Indonesia, the Philippines, and Vietnam. We have only a social security agreement with Philippines, so we need to expand that. And also it would be great if we can think about mutual authentication of qualification, but we have a problem because we don't speak English, so we have to start with the education in the early stage of life. And it would be great if we, foreign nursing care or healthcare workers can come to Japan and live or go somewhere, just like EU countries. That would be great. Thank you very much for your patience and listening.
As my previous experience is lectural, university and academician, so always academicians want to stand and always they talk. They don't stop. So, the story of Jordan, I think, is a little bit different than any other countries. And I believe we are the first countries in the world, or number 1 in the world, have received refugees. So we got refugees in 1948. And after the occupations of Palestine. Then we got also in 1967 another bulk of refugees. Also we got on 80s and after Gulf War, and we are expecting now to have some also in this war. So you imagine a country, populations about 10 millions, 11 millions. Half of them are refugees. Just imagine how burden on the countries, how burden on education, how burden on health services, and this is also there's opportunities and challenges at the same time. So the government start to think and to put policies and regulations, because some of the refugees are highly educated and expertise. Some of them are physicians, some of them are dentists, some of them are nurses, and also we got at the same time the Jordanian, the local people. So the country put regulations and policy for those who are non-Jordanian. If they want to practice the healthcare services in Jordan, they have to. First, they have to have their licensure. And the licensure mandate to have a licensure exam. If you pass the licensure exam, you are entitled to get a temporary licensure certificate or pass. This is a yearly, should be renewed. So those non-Jordanian, they can practice, but at the same time they have to have the licensure, and it's a temporary, because we expect one day to get back to their home. This is point 1. Point 2, to get the licensure, they have to have a contract from the hospital or from university, the area want to hire you, you should have an initial contract. So based on the initial contract, we can offer you as the government for you the licensure, because we make sure that you have someone to employ you. This is the first point. So this is different in anywhere. On the other hand, Jordanian are not a rich country. We don't have oil, but we are rich in human resource. Therefore, you find many of Jordanian, or most of the Jordanian, used to study the bachelor and the higher the specialization and the studies, even for the poor people. Poor people are willing to sell their house for teaching their children. This is a good idea in the Jordanian culture. We are love and fan of studying and teaching our generation. The healthcare workers are highly skilled and expertise. Based on that, and based on the reputation of the Jordanian expertise, we got a high demand on the Jordanian healthcare workers overseas. So you find thousands of Jordanian healthcare workers, physicians and nurses and other healthcare workers on the Gulf area, working on the Gulf area, on the Arab Gulf area, on Saudi Arabia, on United Arab Emirates, on Kuwait, and etc. Not only that, now we found Germany are also looking forward to get more nurses from Jordan and physicians. Looking back to the policy, we are talking about policy now. Is there any policy that manage or regulate the migration in Jordan? To be honest, we don't have any regulation currently to regulate the migration. Why? Because we want more of our healthcare workers to go and to work overseas in order to transfer the money to the Jordan. This is what we are looking for. We are exporting our human resource to the neighbor countries, and they are highly skilled. This is the point. Because the Jordanian staff are highly skilled, they are on high demand, and many countries want them. Therefore, nowadays we are looking forward, the Jordanian Nursing Council, we are looking forward to start to formulate something in this aspect to manage the migrations. We are not against the migrations. No, we are supporting, because we graduate yearly more than 3,000 nurses from Jordan. The need, not more than 1,000. So we have extra. So we want to market. We want to sell our expertise overseas. Therefore, we are looking forward to have a policy to regulate the migrations, to have ethical migration management. Why? Because we don't want also to drain the expertise and to depend on the newly graduate. We want the vehicle to keep driving. We need to train, and we want to also to send someone overseas. That's why the council are on the process in establishing center for training to prepare the newly graduate to work overseas in Jordan and outside Jordan. This is all about Jordan, and we'll talk tomorrow about more in depth about the profile of Jordan. So I'll leave some for tomorrow. Thank you very much, and have a good time.
Okay, thank you. Ms.Mancharee, please.
All right, thank you so much. I think I've heard from very important from both countries, and I could learn the lesson. From Japan perspective, I believe Norway could definitely be, let's say, the same definition of the social sectors and how they have the, welfare. Because Norway also needs people to come in, but at the same time, the challenge I'm facing that I'm going to be sharing with you guys, all of you later, it's very promising things that instead of going through these barriers, why can't we just work together, not just one particular region, but also like the rest of the world? And this policy that I, who's a living proof of the problem sitting here, would need all of your help in the future. And from the Jordanian perspective, I believe that you are producing high quality, good qualities people that could be exported. And there's always a country that may be needing more health workforce. Thailand in particular, we cannot even produce enough doctors or dentists to into the system, and now because the system is abusing people, a lot of us are resigning from the governmental sectors, and now we are facing healthcare, like health workforce shortage in the country as well. So from my perspective is that just to give you a background of the country I'm going to, Norway is very small. It has 5.5 million population, and 20% of the population who are Norwegian are actually either from a foreign descendant or they are the foreigners themselves who switch and become Norwegian, which means that it's a very diverse country. But how come when you don't speak the language, it became the barrier? I don't have a clue. I went there with a very promising background. Like I said, I speak 4 languages before I went there. But no matter how many languages you are speaking, if you don't speak Norwegian, then it's not counting. So I was like, you can speak any broken English I would understand, but I would prefer to speak their own language. And this is irrelevant information, but it's discriminating not just to the practitioners, but also the people coming in. Did you know that in Norway, if you want to donate blood, you have to be able to speak Norwegian? And if you don't speak Norwegian, on the Red Cross website, it's written in Norwegian, say, du kan gjøre andre ting, which means you can do something else. You can do good, better things instead of donating blood. I was offended from the inside and the outside every single minute I was living there. Why? Because I have the competence. In Thailand, I can just go around, help people. I can inspire so many students to be like me, to be parts of the international organization, to be part of advocating for the region. But when the minute I arrive in Norway, I'm not even considered the same. I didn't understand why, but this is me sharing the pain that the barricade and the barriers is set towards certain people. Because in Europe, there's something called an EU agreement. So if you graduate from Europe, you don't even have to speak the language. You just graduate with a degree. You can walk into Norway, become a pharmacist, and learn the language within the country. But me, who is outside of the agreement, I come with an even longer degree because I'm going to graduate with Doctor of Pharmacy, which takes 6 years of my life to become advanced. And they don't even consider me practical until I speak the language. I see that, I understand, we have to communicate with the people. But the question is, you put me in a language program with everyone all the same. The ability to learn Norwegian with the course that the government provide is so slow because they have to provide everyone. So I was in a class with someone who probably have never attended school in their entire life. And it made me frustrated. I lost everything. I packed my whole life to go to Norway to be there for someone else. But what about me? Everybody said I have to do it for my husband. Everybody said I have to do it for my child, which I'm willing to do so. But what about me? I left everything here, my friends, my family, my degree, and my pride. It's indescribable how frustrated or how small I felt. I thought I was going to become one of the key players in the healthcare workforce in Thailand. And now I just have to move because it's smarter. Why would any health workers have to move countries? Because it's smarter. I don't get it. I love my countries. I love Thailand. I think there's so many possible way to be here and improve the health, and we can share things. But at the same time, when I chose to stay here, people around me say, you are not making a smarter move. I said, but your country is not accommodating me at all. If you want to apply for the pharmacy equivalence in Norway, you have to speak the language at the B2 level, almost N1 to Japan, like to Japanese, and you also need to go to take the course, which is going to be in Norwegian, for 6 months. And also you have to take an exam to pass. And did you know that in Norway, if you want to study master program in pharmacy, you also have to be authorized. So I was blocked all the way around. I cannot even go in academia. People said academia is always a comfort zone for healthcare workers, but it wasn't for Norway. I cannot even apply for any single programs just because I don't speak the language. It's frustrated. I'm just emphasizing how unsmooth it is to just move countries. And then, like I said, the boundaries and the borders, the minute I step out of Thailand, I'm nothing. Why is that? WHO, everyone, social sectors, private sectors have always praised for healthcare workers because we are the front lines and everything. But they probably didn't remember that we're also human too. It took me 6 years to study pharmacy school. My whole life I dedicated, and now it becomes just a small part of whatever achievement that they don't care, because I cannot express it in Norwegian. So I'm telling you right now that I'm not going to stop, but there are so many who did. We have doctors, we have dentists in Norway who didn't pass the exam for language proficiencies, and now they're just there. They're just there as housewife. They are just there as something else. And my question is, why would you lose the opportunity to have someone working for you? This is not just an opportunity cost for a person. I'm losing for sure, but Norway is also losing as well. You are losing an ability to have your patients being treated. You are losing your ability to have a better system. They all complain about how shortage we are in healthcare workers. But the question is, why can't you just accommodate and make it better? We have 2,000 young nurses who are ready to be feeding into so many countries from Jordan. How could we work together to bring in and make it less discriminating that if you are outside of EU, if you are outside of the region, how could we make it work? Because, like I said, you cannot really prevent yourself from falling in love. I'm not just talking about a person, your job, the countries, anything. You fall in love with something and you want to stick to it. Mine might be a person, but some people could be a countries. It could be anything. We weren't born into your country to just be there. We are here to explore, and that's a part where we call global citizens. So the concept I would like to promote is that healthcare workers should be valued, and if ever we cross countries, it doesn't mean that we have to fast track, but could you just make the step easier? Make the program where language training for healthcare workers could be tailored for them, so that you also can specify and make it work so that they need to learn what they could, instead of just focusing on how can I order pizza. I'm just saying that we need to learn what is specific so that we could start at the minute we get there. It might take me 5 years to be as fluent in Norwegian, and those 5 years, how many more lives I could save? How many more quality of life I could increase as a pharmacist, as a healthcare practitioner? And now my choice is just to consider, what should I do? What else could I do? So my final remark from today is that instead of focusing on a language proficiency, I would like to aim and have a go on how could I become a better healthcare practitioner, not just how could I be better at speaking Norwegian. But last but not least, what I would like to say is that it's not even easier for my husband to come to Thailand either. He speaks Thai, but it's really hard for him to become a dentist in Thailand and also a doctor, because he has to take 4 license exams for each profession. And these are taking years for medical doctors and dentistry students in the country to do. the pressure is on both of our sides, and we are both practitioners, and no matter which way we do, we lose something. But I hope that with a good policy, with a good approach, we could gain something out of this as well. Thank you so much. Divya will be taking the floor from me from now. Divya, enjoy.
Okay, thank you, Khun. So I think we can start with our panel discussion too. So having heard about the policy challenges in health workforce migration in our first panel discussion, I think it's really important to shed some light on the successful collaborative efforts as well, because there have been many bilateral and multilateral agreements, and in huge part due to conferences like this, and because of experts like the ones joining us today. So through this panel discussion, we will learn about global health diplomacy and international collaborations and their outcomes. So I'd like to welcome our first panelist, Ms.Anna Kurniati. She is the Director of Health Workforce Deployment at the Ministry of Health in Indonesia, and she's also the chair-elect of AAAH. So Indonesia has been reported as both a source and destination country for health workforce migration. So Ms. Anna will be able to provide us with some context on bilateral agreements with tangible, successful outcomes that benefit healthcare workers both intra and interregionally. Our next panelist, Dr. Krishna Reddy Nalamala. Please welcome Dr. Krishna. He is a board-certified cardiologist renowned for his expertise in comprehensive primary care, digital health, and integrated care. He is currently serving as the India Country Director for Access Health International, which is a nonprofit organization dedicated to enhancing global access to high-quality, affordable healthcare. Dr. Reddy's insights are particularly relevant to our discussion on the international migration of healthcare workers. And finally, I'd like to welcome Dr. Rupa Chanda as the last panelist for the session. She is the Director of the Trade, Investment, and Innovation Division at UNESCAPE. Dr. Rupa's economic perspective and research focus on migration align seamlessly with our exploration of the complexities surrounding the international migration of healthcare workers, including potential negative impacts and the need for greater cooperation with the health sector. So starting with Ms. Anna, the floor is yours.
Thank you for the opportunity to share with all of you a very good afternoon. As the moderator already introduced me, for this session, I would like to share how we manage collaborative with our key stakeholders in order to strengthen our local health system, our national health system. But tomorrow, my colleagues will also talk specifically about how we transform our regulation in terms of managing international recruitment of health personnel in both ways, inflows and outflows. So today I will speak about how we collaborate with our national and also subnational stakeholders in order to improve the availability and also the distribution of our health workforce. Excuse me. Okay, so So I will start with the current situation of health workforce in Indonesia. Although we can say that Indonesia already have sufficient in terms of the ratio of health workers, doctors, nurses, and midwives per 1,000 population above the minimum threshold that already stated by the WHO, we still lack of medical specialists. So as you can see here that the shortage of medical specialists occur in almost all regions, except maybe in Java region. And when we calculate the number of medical specialists in all specialties, and we compare to the supply in terms of the production from the training, in Indonesia, previously maybe a bit different from other countries. the production of medical specialist training from university-based, not hospital-based. So the number of those that already completed training every year is still very low, approximately only around more than 2,000 per year for all specialties. And only 22 out of more than 100 medical schools in Indonesia provide medical specialist training. So that's why the number of production each year is still very low. So as we can see here that we have approximately almost 1,000 district hospitals across Indonesia. However, only 40% that already have minimum number and type of medical specialists. When I said minimum, it comprised of 7 types of medical specialists, like pediatrics, OBGYN, and also surgery, and radiology, anesthesia. So in terms of other specialty, we are still very lacking. So that's why our government has commitment to improve the health system in an integrated way as a transformation of the health system. There are 6 pillars. The first one is to support the improvement of the primary care. The second is to improve the referral health services. The third is to improve the resiliency of health system. And then the fourth pillar is to improve the financing. And human resources for health is the 5th pillar under our transformative health system. And the 6th is for the transformative in utilizing the digital technology. So in the 5th pillar, we are focusing on scaling up production of health workers that we consider still shortage in Indonesia. For nurses, midwives, we consider we have more than enough supply because the number of graduates is almost 100,000 per year with 2 types of different levels of competency. The first one is from diploma 3 level and the other one is for bachelor degree level. But for medical doctors and especially specialist doctors, we are severely still lacking. So this is our priority programs. In order to provide, to improve the supply, we provide additional specialist program. And now, using the new law, we already launched a new program that producing medical specialists not only using the university-based, but also the hospital-based. I think most countries that we already did the benchmark previously, producing medical specialists usually through residency training at the hospital. And we also provide a scholarship for medical doctors and also for other health workers that consider still limited in number. And for the distribution, we also provide new regulation. Tomorrow my colleague will also tell you, to invite our diaspora from overseas. Previously they have problems when entering our country and practice in their own country because of the evaluation competency exam is not that easy. And we also have recruitment of civil servant, very high in number since 2 years ago, to improve the availability, especially for the district hospitals and also the community health centers. And also we have some quality improvement, including a fellowship program for medical specialists. So we have a number of key stakeholders to work with. For example, in the terms of production, we collaborate with MOE, and it was tough to convince MOE to, to change the system on the way producing medical specialists until the law already passed last year. So that way we can collaborate with MOE and also with other universities and teaching hospitals on how to improve the education system, especially for medical doctors and also for medical specialists. And we also do the workforce planning, and currently we have the system using a digital technology comprising not only the provincial level, but also up to the local level, that we use the same system, digital system, to do the planning of the workforce. And we also integrate the system with the Ministry of State apparatus to ensure that the formation for recruitment of civil servants also have the similar platform. And we also have the deployment mechanism. We work with the Ministry of Home Affairs because health is decentralized, so we have to work with them because public health facilities at the local and also subnational levels owned by the local government. And we also work with the Ministry of Finance to secure funding because most of public health facilities hire civil servants. So funding to hire civil servants mostly come from the specific grant from the Ministry of Finance to the local government. So we secure a lot of funding to have the vacancy filled, especially at the district and also at the sub-district levels. And we also have quality improvement, so we work with the councils and also with the local government to make sure that everyone, even far away, can access the training programs. So now we already have the learning management system. It's free to access by all health workers. So when they are in a remote place, they still can attend the trainings through the online system and also through the self-learning materials. So this is to provide you with some insights on how we achieve the program since the transformative health system already launched since 2000, at the end of 2021. After we struggle with the COVID-19, we work on this and we made a lot of achievement by changing the regulation, including passing the new omnibus law. The process was in less than 1 year until we issue a new law that accommodate these programs so that we can accelerate and also gather supports from our key stakeholders to do this program. So you can see the number of bonding service for the scholarship and also hospital medical specialists. We will open for selection this year, and also special assignment to support the local government, especially in remote and rural locations where the government still have problem in hiring. So Ministry of Health conduct this special assignment and to reach out not only for the health workers for the community health centers, but also for the hospitals, including using the resident senior, those that specialist training that already in the last stage of training. We also make them having rotation to the district hospitals. And also we changed the full registration. Previously only 5 years, and they have to renew every 5 years, and they have to submit some heavy documents to the council. But now we apply of lifetime validity of their registration certificate. So basically they only need to renew their license to practice, but not the registration certificate. And the digitalization of the training system that I already mentioned, this is an automatic providing credit points for those that already completed the training and also already having a post-evaluation after the training, so they eligible for the automatic credit points that is very necessary for them to renew their license of practice. And also recruitment of civil servants. We have more than 100,000 civil servants hired since 2022. So that's all from my presentation. Thank you very much.
Good afternoon. I don't have presentation. Since the topic, if I understand from the first panel as well, every country has a problem of health workforce. And the problem is common to all the countries. The question is, how do all countries collaborate and cooperate to address this problem in a collective fashion? That starts with the premise that world is one family. If the starting premise is that I'm Cuba, I'm Jordan, I'm India, we may not find a solution. I think the premise should begin with an agreement that we are one family. The knowledge moves across the borders. People move across the borders. I mean, they have been moving for the last millennia. And the goods move across the borders. I think this is the understanding that unless these move across the borders, the world does not function. So if that comes to the understanding, then what happens in India? Because in the morning, there was a discussion in terms of the language problem. We have 100 languages. Different states speak different languages. 28 countries, actually it's 28 countries, not 28 states. Like UP, Uttar Pradesh, with 200 million people is on size of European Union. So if you can find a solution in India, you can find a solution for the world. Because you have multiple religions. We have migration from Africa. We have migration from Central Asia, Caucasians. Then we have migration from Mongolia. So you have all the races. You have all the colors. You have all the languages. So if you can find a solution for that. So the solution is, how do you harmonize your competencies required of a health worker across the world? I mean, the competencies don't change. For a healthcare worker, if it is a nurse, if it is a doctor, the competence is same. The knowledge is same, the skills are same. Why there is no attempt to harmonize this curriculum? If you harmonize curriculum, they don't have to spend 5 years again struggling to relicense. So that is one, I think, a policy decision, a global policy decision of, I mean, just like it's happening in the pharmaceuticals. There is an attempt to harmonize standards across the world. So harmonizing curriculum, harmonizing the standards, harmonizing the knowledge required, the competencies required, the skills required, I think that eliminates one hurdle of cross-border migration. That's one. The second is in terms of understanding, whether it's a regional understanding or international understanding or a global understanding of how do we license the people across the world. So that is the second thing in terms of the licensing of the workforce, licensing of the workforce. The third collaboration that can happen, I mean, in terms of producing the workers, you don't have teachers, enough teachers in each country. You don't have enough competent teachers. You have teachers, but not competent. So to have competent teachers in the world of telemedicine, in the world of teleeducation, why not the world agree that a competent teacher in India can teach somewhere else? Or a competent teacher in the world, anywhere in the world can teach anywhere in the world. So that is the third element. Third element in terms of collaborating in terms of the faculty to impart the required knowledge and the skills. And the fourth is in terms of pooling of resources when there is a crisis. I mean, this concept of pooling of resources, whether it's financial resources, whether it is vaccines, whether it's knowledge, whether it's people, applies anywhere. So if you have, I mean, the WHO has a public health emergency force, but it's not sufficient. It's not agile enough to respond to a requirement in every country. So why can't be there a regional understanding, an international understanding of creating a public health emergency workforce which just get deployed, waiving all the rules of cross-border entries during a public health emergency like the COVID, or any geopolitical, you have the medicine sans borders. It's nothing but an emergency response force wherever there is a need. So that's the fourth level of cooperation. The fifth level of cooperation, which does not require, does not know the boundaries and the borders, is the AI workforce, the artificial intelligence workforce. So if there is an artificial intelligence doctor, because it's a cognitive skill that is required, then there has to be a discussion from the WHO, from the United Nations, from the bodies, as to how do you engage the AI doctor, which does not know the borders. And AI doctor also does not know the language. They can speak any language. So that problem of language will be addressed. I was responding to the problem of language in India. What happens, somebody from Punjab comes and works in Telugu language. So we give an assistant who speaks Telugu to the doctor. So there is no, I mean, the patient does not feel that they can't understand the language. So that is a other thing that, that can happen. I mean, these are, I thought, from a loud reflection in terms of, because I reflected, I mean, what is working in India? I mean, we have a common exam, entrance exam. We have a common exit exam. We have a common license. Like in one province, if somebody is licensed, they can practice anywhere, unlike the US. US has separate license, and they have to waive that license restrictions during the COVID. But why during only COVID? Why not every time? Especially with the telemedicine, it does not know the boundaries. So there has to be rethinking in terms of licensing, the cross-border licensing, even within a country. So these are, I think, a few thoughts in terms of from a global health policy level, as well as the regional health policy level, and some of the large countries like Indonesia and India, which have their own internal, intranational restrictions, which are artificially man-made. I think they have to be broken. I stop here. I think these were some of the few comments in terms of collaboration.
Good morning, everyone. I think I follow kind of on the issues that Dr. Reddy raised just now, which is on where is the scope for collaboration. And one of the things that he picked up on was on harmonization. So I'll be elaborating a bit, maybe getting a bit more into the micro level of it, or where do we see the evidence of collaboration, especially in terms of regional groupings, and are there successful sort of outcomes that are present, which could be used. So what I would like to highlight here is why do we need to look at these kinds of formations of regional blocks or other sort of frameworks that exist at the regional level, which could be leveraged for managing cross-border health mobility? And then what exactly are they doing, and what are the gaps that exist? What happened there? How come it's not going to the next one? Okay. But let me also give a bit of context. This comes from the work that Ibadat mentioned, you know, the expert advisory group that was set up on, you know, ethical recruitment of health workers, where one had gone into various regional groupings, and I've just selected 3 out of the ones that were there in that particular exercise. So I'll be focusing on the Caribbean, Africa, a little bit of ASEAN, just to see what is the evidence on the ground. Okay. Is there a problem? Should I do, or someone else is doing? Okay. So just to motivate why we need to look at managing cross-border health mobility, especially, you know, regional collaborative mechanisms, but also give a little bit of context on the bilateral what is happening in terms of sending and receiving countries, just a few examples. And as I said, what are some of the gaps that one can identify from the existing processes and where one needs to focus, especially organizations such as the WHO. So I think, oops, why is this flitting all over the place? Okay, so if we just look at the motivation for this, we know we're talking about sustainability of national health systems, and this depends on a wide range of things, not just the human resources for health factor. You can talk about physical infrastructure, you can talk about education, etc., wages, working conditions. But in a broader sense, all of this kind of leads to what is the sort of human resource capacity that you have in the health sector and how you manage this, both for your national benefit, but if you think of human resources for health as a global public good, or a regional public good, then of course, coordination becomes important there. Now, the context is that there is an acute shortage of health workers, and some regions face this more than others, especially the poorer countries. You have sub-Saharan Africa, for instance. And an important determinant of human resources for health, as we heard in the morning, is migration. So this does have a major impact. This is just very quick statistics on the dependence on foreign health workforce. In some countries, it's as high as 30–40%, especially in the case of nurses, it's very high. So there's something going. So if global, if human resources for health are a global public good, then they need, just like any public good, you need coordinated and collective action. And as we know in economics, any public good where the marginal social benefit exceeds the marginal private benefit is going to be underprovided, okay? Because you're not going to see the larger returns for beyond your national sort of requirements. So that is why you need both sending and receiving countries and groups of countries to take coordinated action. Now, as Ibadat mentioned in the morning, there are governance mechanisms at the global level, and these are trying to discourage international recruitment of health personnel in countries, from countries which are facing shortages. They're trying to focus on more of mutual benefit, so training in health education, better retention strategies, etc. Now, while these global frameworks are providing you these guidelines and principles, I would think that the evidence on the ground doesn't suggest that there's really been that much of implementation. There are references to these codes. These do provide some guidance, but perhaps where really the action needs to be is at the country level, bilaterally or regionally. So bilateral management is important. Regional cooperation mechanisms are also important. Why regional? And because this is the thrust of the presentation, because increasingly you find a lot of intra-regional flows of health workers. It's not just the classic, push-pull factors between from the low-income countries to the high-income countries, but there's a lot of movement among the lower middle-income countries as well, and there are hub and spoke sort of things that are operating in various regions. And that actually makes it more challenging, because many of the countries which are sending are shortage countries, but the ones receiving are also actually shortage countries, of course, because of that. But then they are also having out-migration to third countries. So it's really a very complex sort of dynamic of migration that's happening. So in terms of bilateral collaboration, there are, this is evidence from the WHO, you have a lot of separate bilateral agreements which are looking at the facilitation of movement, they're looking at qualifications, harmonization, etc. And as I said, they're aiming to serve the mutual interests. Now, if we just look at some examples, for instance, you have the classic sort of high income, low income sort of agreements. And I won't go into the details of this, but they give you a sense of where the thrust of these bilateral agreements is. A lot of it, I would say, if you really look closely at the text, is about how many workers will go, under what conditions, to just ensure that it's safe, orderly sort of migration and the people go back. In some, you have some mention about training, capacity, etc., and return migration. But I would say largely, they don't really focus on the mutual benefit part of the agreement. It's more from a receiving country's side, how many they will take, how they will regulate, what are the requirements you have to fulfill, etc. So 100 nurses will go. And the numbers are quite small, given the kind of requirement that is there in many of these receiving countries. So you can say these are pretty asymmetric in some sense. In fact, I should also mention in this context that I got a doctoral student to actually look at some of these bilateral flows to see how much of actually reverse flows are happening, in the context of FDI in the health sector. It doesn't have to be through training and capacity. It could be in many other ways which you could build up the local national health systems, which is through ODA, which could be through FDI. It could be, in terms of collaboration between institutions. And what you find, especially on the FDI side, you don't really find a two-way sort of flow. So it's basically a one-way. People are getting trained in one set of countries. They are flowing to the other country. But if you look back at what are those countries sending back, of course, remittances, ODA, things like that, you can't track at the health level. But the FDI you can track, and that could be a major sort of reverse flow that you could have into the health sector, infrastructure, into pharmaceuticals, etc. And you don't find that at all. And this is one area I would suggest one looks into more closely to make things much more equitable and mutually beneficial. Next slide. Yeah, so these are just, a smattering of some of the agreements and what they cover. But as you can see, they're really numerical sort of exercises and border regulation sort of exercises. Next. So now let's look at the sub-regional. I would not say even regional because they're really sub-regionally focused collaboration mechanisms. And what they broadly do is to establish some of the guidelines, the policies. But what's important is at the regional level, you actually find institutionalized mechanisms which at least provide a starting point for some of these discussions, like what was mentioned on harmonization, and some go further than that. What are some of the things they address? Well, yes, of course, recruitment, standards and qualifications. That's the main thing, actually, I would say mutual recognition, mostly focusing on nursing, but some go beyond that as well. They are talking about even harmonizing training and capacity building through needs assessment, identifying what are the gaps in some of the countries. Some go beyond and look at, what are the regulatory bodies, not just in the training area, but also beyond that, like for products, for instance, how do you need to cooperate? Data sharing is talked in some, but this is an area which certainly needs much, much more cooperation. Return and reintegration to some extent, but not to the extent required. Next. So I'll give the example of CARICOM, for instance. So the Caribbean region, which has a shortage, there's a lot of outmigration to North America. And you have aggressive recruitment also from North America. This is a region overall, also there's uneven distribution amongst the region itself. Now, one of the interesting things is that you have an institutional mechanism here to coordinate health policy at the regional level. And there is the Caribbean Cooperation and Health Unit. And they have been looking at human resource for health management, keeping both the internal, intra-regional migration as well as the out-migration flows. Next. So they have a policy, of course. I mean, policies are on paper. They're never fully ever implemented, of free mobility. They focus on training and accreditation, quality upgradation, and sharing of best practices. This is something that's important in the regional context because you find a lot of these sorts of pilot initiatives to look at what are the good practices across countries. There is a managed migration program with regard to nurses. There are regional associations and bodies that have been set up to develop minimum standards for licensing of nurses, recognition of doctors who have been trained outside the region. And another interesting feature for CARICOM is for the returning workers, health workers, especially nurses, how do you actually use the skills that they have developed, the networks that they have to actually build the capacity within the country. So this comes back to the issue of how do you actually use return migration, how do you integrate people, but how do you use the skills that have been formed overseas when people return to benefit your health sector. Also interesting is that you have coordination efforts which extend to other health professionals. So you have for pharmacists and for medical products. Next. So this is, I won't go through all this. This is just more of the process and the institutionalization of some of these processes. It is important because it is important to set up bodies, to have regular dialogues. It is important to have deadlines, timelines for delivery of things. Otherwise, things lose their credibility. Next. Just just, in the interest of time, I don't want to go into all this detail. Next slide, please. I think they're busy talking. Okay. Okay, so these efforts also, another important thing is that you need evidence to guide the regional effort. So you need studies to be done. You need analysis of what the needs are at the regional level. So some of this has been done. I won't say, it's extensive, but there have been efforts. And if you look at the BSc nursing reform, it's been based on guidelines, based on a minimum sort of curriculum, looking at the needs of the region, mapping the requirements, etc. So it is evidence-based and driven. Yes, of course, challenges. Challenges because there are multiple stakeholders. Like we said in the morning, it's not just about ministries of health. There are multiple other stakeholders. And one of the points that was made, like what really prevents cooperation, a lot of it is also regulatory bodies and their sensitivities and their sort of protectionist interests. So that's one of the issues. Funding is a major issue in most of the regional examples, if you look at it. And then again, you need legislative support. Sometimes you need to push through reforms through legislation, and that means political will at the highest level. That's also difficult. Okay, East African community, another interesting example. So these are the countries. And again, harmonization efforts here. Several institutions which have been used to support regional harmonization. You have an inter-university council, you have the Health Research Commission, which does a lot of these background studies, and then you have a secretariat. And here you have several regional boards and councils which have been established. So the point I'm really trying to hammer here is the importance of institutional mechanisms and setup. And that requires a lot of cooperation at the regulatory level. Again, what have they done? There's a whole list. This is all the process, but let me just distill what is really there in terms of the process. Setting up of some of these regional sort of consortia approaches, arriving. So what they did also similarly, they actually did a needs assessment. They found out what are the gaps, what are the requirements. They came to some minimum sort of checklist of things that are required. And of course, these findings were shared. So it's also something that's driven by the member countries. It's not just imposed by, one set of evidence. And then efforts to make sure that compliance is there with these standards. Regional boards and councils, which led this whole process. They carried out the inspections. You had the inter-university council. So basically, there was a whole mechanism that was set up for this harmonization. What are the outcomes? Well, this is based on actually discussions with experts in the region. They said it has enabled standardization. It has led to mutual recognition of institutions. The regulatory councils have been strengthened. You have better mobility of resources within the region. You've got economies of scale. Some of these economies are much smaller, but now you have a sort of pooling. So exactly the point that was made. In nursing and midwifery services, one of the areas that was targeted for reform, you have major training and policy changes. And there are more training institutions as a result. There are more nurses available at the regional level. So there's more resource mobilization. The governments have looked at this evidence. They have realized the gaps. Many have put in more funding to address those gaps. More doctors are now registered. So there are many of these sort of beneficial outcomes. It has been a mutually beneficial thing. Yes, there are problems. There have been challenges even in this. And there's a lot more sharing of expertise amongst different kinds of regulators here. An association of regulators has been formed under this as well. Challenges, similar to what I had mentioned in the case of CARICOM, legislative differences across countries. There are still gaps. Implementation is never 100%. The financing is a constraint. Actually, one of the interesting things that emerges across these different regional mechanisms is that you do find that you need the support of some other international organizations. So in this case, for instance, I think the World Bank was there, which was providing some of the financing support. So countries themselves are poorly resourced, so it's difficult for them to push through all of this implementation. And data. Data is another issue which remains a challenge because the tracking of the data on migration inflows, outflows, and intra-regional movement. As it is, the data is poor. Then to talk about all the countries together having a good sense of how much flows are happening between them is not easy. Okay. And finally, ASEAN. this is, I won't say as interesting an example, at least based on the evidence that I got. And here it's, again, the focus has been on MRAs, mutual recognition agreements, and harmonization. Let me just, they've taken steps. There are 3 MRAs that have been supposedly agreed upon, but not really implemented. It's been very slow. And recognition of qualifications has still remained problematic, even though technically there's free mobility of health workers depending on what your visa regimes are and so on. More collaboration is needed. So this is not a very shining example, but I think the CARICOM and the East African community examples are more interesting because they go much deeper in terms of the integration. There have been a lot of challenges in the case of ASEAN because ASEAN is a complex area also in terms of dynamics. You have major outflow countries which are exporters, but at the same time you have a lot of sub-regional movement also within ASEAN. Now, what I'd like to distill from this in terms of the collaborative processes and the evidence that we see is that, one, countries do recognize at the sub-regional level that there is interdependence amongst them. As I said, the bilateral ones are, I would say, sort of narrowly focused. Some are focusing on skilling and training partnerships, but there's a lot more scope to incorporate within them the perspective of the sending countries on technical and financial aspects, and especially, worker reintegration and upgrading of capacity. In terms of regional processes, as you saw, at least on the harmonization front, looking at standardization of curricula, needs assessment, etc., and even getting to MRAs, it's much more extensive. There are, as I said, institutional mechanisms. Mostly they're targeting nurses. They're often receiving, as I said, technical and financial resources from international organizations, which seems to be important. But there are still things to be done. So if you look at them, they're really stopping somewhere at the mutual recognition and standardization part. But how to actually link this to reintegration, to retention strategies, how do you generally kind of improve the overall working conditions and so on? I mean, that link is not really there. It's just on the facilitation of mobility and increasing the pool of resources available at the regional level. Ensuring that things are mutually beneficial, not really. I mean, yes, the outcome has been, like, for instance, in the East African community, you have more nurses, you have more accredited institutions, etc. And again, the ethical dimension, I mean, because even within these regions, you do have countries with acute shortages, so you don't find that dimension within these sub-regional agreements. The link to push and pull factors is not there. So where do we need to focus? I think one of the areas is digitalization, tracking mechanisms and looking at, mapping of the number of workers, etc., and more evidence-based collaboration is required. So thank you.
Please join me in welcoming a true humanitarian, a champion for the underprivileged, and inspiring leader, Dr. Cynthia Mong. So the floor is yours until 9:40.
Provide a little bit more introduction
good morning, everybody.
to you and your work, and to think about
Thank you for
how the poly crisis is impacting the
to share our
work that you're doing
work
right now
and experience working with Burmese refugees and displaced people along the Thailand-Myanmar border. And initially,
okay, good morning, everyone. I'm Dr. Yoli Oliveros. I'm one of the deputy directors in the office of
I think we listen to conference, no? Maybe.
So let me
this one and another one.
That climate, environment, and health are key priorities of the U.S.
Two conference at the same time. That we
And,
do all the time,
the
right?
USA
We have
Climate
online and sometimes we have meeting on
2022
site.
to 2030 was
Sorry,
issued
I
by
think
the
they have
agency to guide the whole of agency approach to reduce global greenhouse gas emissions and help protect countries that we are supporting to build resilience and improve our operation. So, because we know that an effect of climate change disproportionately impacts people living in poverty and those who are marginalized, who are our priority target beneficiaries. So affects virtually everything that USAID does and threatens the development progress we have supported for more than 60 years in all countries that we support all over the globe. So when we say climate change and environment crisis is a global crisis, then it is also a global health crisis. So meaning cause human fatalities, disease outbreaks, mental health issues, among others. So while it is an environmental issue, it really affects human health. So, and not only human health, also natural disasters can also affect economic, social, and
we have to ask them what topic now, so we can
in the Philippines, and I'm sure
understand
Balboa
what they are topic.
The average annual well-being losses due to natural disasters in the Philippines is estimated at $3.9 billion, a big amount that also affects investment, not only of USAID, but the government investment in health. So I'll stop here and then pass it on. Thank you, Dr. Ali, and morning, everyone. I'm Dr. Gloria Jacinto Balboa, and I'm with the Philippines Department of Health for, say, more than 35 years. I hope I don't really look that old, but I'm proud to be a senior citizen. Okay. Well, I've started in working in the field as a volunteer doctor in a small municipality, but most of my work has been as a director of 4 different regions in the Philippines, and my line of expertise is more on health emergency and disaster management, having been great.
Before talking about the border, I would like to briefly explain the background. I fled to Thailand in 1988. So the Burma, as you already aware, that since 1962, ruled by successive military regime, and then lack of access to health is very poor, especially in the rural and ethnic area, because the investment on health is very low. And we have since 1962, under the military regime, the ethnic minority fight against their self-determination, and the armed conflicts going on over the past 3-4 decades. And so for the health system in Burma until 2012, that is after the election, general election, won by the civilian government, this under the military regime, our health information is one of the worst in the region, as the maternal death is 2.5 times. We are the higher maternal mortality in the region, second highest. But in the conflict area, we have 2.5 times higher than the national figure in 2015. And for the poor people, the out-of-pocket is the main resources for the health services. And the health workers are mainly
3 of them are really based around solving the 3 global challenges of climate change and health, mental health, and infectious diseases through funding, research, and advocacy. And then we also have a discovery strand that is basically funding science.
Health workers being recruited.
To help improve people.
Recruited mostly from the city and most of the poor area or ethnic region, and lack of health workforces and national health service not reach to the poorest people in the ethnic community.
What are the effective mitigation solutions?
So because of the conflicts going on, the first time in 1984, the refugees fled to Thailand. So currently there are almost 100,000 refugees living in Thailand since 1984. Some of those resettled, but some of them still remain. And also internal displaced. This is before the military coup. We have stay almost, even under the ceasefire between the ethnic organization and the Myanmar military, there are still 350,000 internal displaced people. And after the military coup, February 21st, the escalating of the conflicts and the militarization and human rights abuse, this forced many people from home. So today, as of today, almost 2.6 million people are displaced internally, not only on the border area, even in the central region. So back to Medoc Clinic, I myself, I fled to Thailand. During those time, many university students and health professionals fled to the border because of the insecurity inside. So during those time, we start setting up the community shelter because displaced people need shelter and food and medical referral system. So since that time, we start working with the local Thai government hospital to initiate the cross-border medical referral system. Because many people in the internal displaced people, access to health is very poor. The primary level care is taken care by the local ethnic community health worker. But for accessing advanced level care, need to refer to Thai government hospital through the cross-border. So over the years, Medoc Clinic grew into the comprehensive health center, including maternal child health, vaccination, and the community outreach program, working with the school and working with the community volunteer. And we are also become the link between the Thailand and Myanmar services to access for the like life-saving emergency service. Also, we continue train health workers on the border. So our health workers training is different from from the national level or other country because we have very limited resources. We have to start with the 4 months or 6 month community health volunteer trainings. After working experience for 2 years, we can upgrade then another 10 months to perform the basic like a maternal child health or basic medical services. So based on the tax, we have to train them like a tax specific the training curriculum, and that so over the years we train more than 3,000 health workers. Some of those continue stay working at the clinic, or some of those return to their village or community to continue serve for the internal displaced people, or some of those already resettled to the third country. So I would like to highlight how we have been existed or the significant or present in Thailand. No? So the migrant and refugee population is very limited access to the Thai public health system because they do not have health insurance or legal documents or cannot afford to pay. So we are serving migrant displaced population for over the 35 years. And many of those, they never been to Thailand, or they are the first contact they come from, refer from inside Burma. So to go to the Thai hospital directly, it is challenging for them, like language barrier or what service are available, and also the affordable to pay. So we are the first contact for vulnerable population. And we have a well-established system with the Thai government hospital and other international institution which provide like a clinical services. Like for example, one of the NGO focus working on the TB HIV. So for access to TB HIV treatment, we have to refer to other centers. So we have a good connection with other hospital for continuity of care. And we also work with community volunteers many displaced Burmese people themselves, whether they were working in the factories or in the community. They are also community volunteer, and they do disease prevention and improve access to health insurance, or maybe they also have to continue follow up for care, like for example, TB, HIV, sometimes you need the continuity or you don't want to drop out. So the community volunteer network is very broad on both sides of the border. And with the limited resources, we can also sustain our program. And since our health workers are also come from Myanmar and they are speaking in ethnic language or English or Thai, Burmese, also we have to work with both Thai and Myanmar or ethnic people to able to make a more client-centered approach. And we continue train ethnic health workers, especially after the coup, there is more demand for the health workforce because number of displaced population is growing rapidly. And we also become the learning center for the border health because many international universities, including Mahidol University or the local university, while they want to learn about the border health issue, they come to us and we share our experience, knowledge, how the migrant refugees and border health being developed over the years. And all the health workers are locally recruited. Some of those we also recruit some of the Thai nurses, or some of those are the local community volunteers. They themselves are refugees. And we also have continued support from the local Thai authority and international community. The history of collaboration with the Thailand Ministry of Health is that since 1990, we start working with Ministry of Health, like Masa Hospital for referral services, access to the life-saving emergency service or special investigation. And then in 1995, the Ministry of Health provide us vaccine for children. EPI program started until now. So even like expand to like during the COVID period, also we get COVID vaccine from the Ministry of Health. In 2012, we started a disease surveillance system and outbreak control. So during the COVID, we are also become the treatment center, one of the free treatment center to take care of the undocumented or migrant population. And HIV access to ART, so this is challenging for the migrant. But since we have been working with both Thailand, Myanmar, and both like Myanmar Hospital, so we have a network of the national HIV program or Thai national program. So improve access to HIV, ART for HIV patient. And working with the public health and continuous medical education program for health workforce, in 2005, we started a school health promotion program because on the border here, many children cannot access to the Thai education system as well, because since they fled to Thailand while they are 10 years old, 15 years old, so not easy to go to the Thai health system. And because of the language barrier or because of the limited capacity for some Thai education, primary education center. So the migrant learning center being set up by different community. So in 2005, Mesa Hospital and Medical Clinic, we work together to improve access to health for migrant, especially for health promotion activity in the school. And starting from 2006, we work with local Thai hospital in Samngmueang and Remark district for clinical internship because we train the nurse aid trainee to perform the nursing or patient care at medical clinic. So we work together with the local government hospital for clinical internship opportunity. And also with the Khon Kaen University, we want to upgrade our skill knowledge of the health worker, not only from medical clinic, from the ethnic region, for the health administration or health facility management certificate course. And also with the Thammasat University, we train more than 2,000 health workers to be able to perform like a public health intervention in the community. So before move forward, I just want to highlight things about happening in Myanmar. So since the military coup in 2021, the influx of refugees and migrants is growing into Thailand because of arrest of civilian and arrest of human rights activists. So when the military coup happened, the first group, one of the first group who protests against the militarization is the health workers. They are the health professionals protesting the military coup. And since that time, many health workers being targeted under threats of arrest or detained, and even some of the health facility being raided. So on the border and also in Myanmar now, we have facing the challenge of human resource because they are hiding or they are detained or they are displaced. So according to the network of like called CDM, Civil Disobedience Movement, so almost 450,000 health workers are displaced from their workplace. They are hiding or they are detained or they are displaced to the border. And in Thailand alone, now in Masao area where we work, there are almost 400 health workers, health professionals like doctors, nurses, and specialists, and the nurse, they are displaced into Thailand. And many of health workers who are continue working inside also, they are threats. Because some of those working or displaced to the ethnic region where the conflict, in the conflict zone. So in the conflict zone is continue threats of like airstrike or bombing or shelling. And so they are also working under difficult situation to perform life-saving emergency procedure like cesarean section or other war casualty management. And so due to the violence, conflicts, the health, these are the data coming from the insecurity inside or other health agency, how many health workers being arrested and 200 health facility being damaged or killed, or so these are some of the evidence showing that they are the health facility and health workers are under threats. So this is briefly showing about the refugee camp. This is Thai side. This camp, like the orange color, this been existed since 1984. Currently, there are around 90,000 people still living along the border in the Thai side, but they are not allowed to move outside the camp unless they have the health reason. So many children or health workers who are working there, they were born there, they grow up there, but no education, continued education opportunity for them as well. So the current situation, we have internal displaced population. So many children, they cannot continue go to school, but the teacher or the community setting up the shelter for the learning as a learning center. And some of those everywhere near the school or housing, they have to build bunker when the airstrike going on. So the challenges on the border are actually as a whole Burma, we have limited opportunity for health workers for their career development. And we also have a shortage of the trainer and professional. And the health workers themselves in Thailand do not have the some of those new professionals. They do not have legal status or registration, even they are very qualified like specialists, or they have to stay as a like undocumented or licensing without licensing. So both inside in internal displays or in Thailand or the whole country, now the health workers are under threats. So for way forward through working with the regional and border health, so we would like to highlight the protection of the health workers. Many health workers do not have legal document, they themselves are displaced. So sometimes they also apply migrant workers like as a migrant worker. But the challenge is they have to register as a like household housemaker or sometimes construction worker, because they do not have in Thailand also the health professional or community health volunteer recruitment is not in the work criteria in this area. And the many health workers also need continue medical education or protection. And we also want to highlight that we need to expand our network with some Thai university or existing, or maybe expand to get more ongoing education opportunity for the ethnic health workers and the displaced, newly displaced skilled professional. And there are hospitals in both Thailand and Myanmar side. So Myanmar side, where the ethnic control area, the ethnic community also setting up a field hospital, working together with skilled professionals, so we can do some more like a technical exchange between two twins, like a twin hospital or two hospital. And for the displaced professional, they need to get the temporary licensing, or there is a way to improve their status or to perform medical services, because of the growing number of displaced people need more medical or health workers, but without proper like documentation and license, their security is still challenging. And then for the refugee and migrant youth, they also need to have more education opportunity to contribute, to continue contribute towards the development on the border. So these are the brief of our experience and explanation. So some of our health workers who were trained at the clinic, and we have opportunity to go to the Thai government hospital under the supervision of the Thai health workers, we able to get a clinical internship program. So these are one of the examples we do collaboration with the Thai hospital. Thank you.
Thank you so much. That was a fruitful sessions. And now we are proceeding to the next panel discussion. And before we move forward, I would like to introduce you to this beautiful young lady here. Sasi Vimon Ontong will be your facilitator for the next panel discussion. So without further ado, the floor is yours.
So good afternoon. My name is Sasi Vimon Ontong. So welcome to panel discussion 3. A smart investment for sustainable workforce solution in the workforce mobility era. So these sessions will focus on innovative or smart investment to scale up health workforce capacity through technologies such as health analytics, big data, health information system, mobile health, clinical decision support system, and so on. We would like to hear about successful intervention of each country and how they come up with solutions. In this panel, we have Professor Dr. Seoyun Lui, please. And Professor Dr. Seoyun Lui is a distinguished professor specializing in health policy and system research, having worked in various capacities, including lecturing on social medicine and health studies in Fudan University, and as a lecturer in health service research at the Liverpool School of Tropical Medicine in the UK. Currently serving as a Deputy Director of Peking University, China Center for Health Development Study. And the next panelist is Mr. Rajendra. So Mr. Rajendra is the Regional Secretary of Asia Pacific Regional Organization of UniGlobal. He held a master's degree in globalization and labor from Social Science Institute in Mumbai, India. With extensive experience in the labor sector, Mr. Rajendra has spearheaded numerous trade union initiatives with more than 50 global agreements and protocols, securing the right of millions of workers. And the last panelist, Ms.Diana from USAID. Ms.Diana Friedmuth is the health workforce team lead in the Office of HIV from USAID in Washington, D.C. She focused on strengthening the health workforce to achieve HIV goals and sustainable national HIV program. She is the USAID co-chair of the PEP Chair HRS Technical Working Group and the Health System Global Technical Working Group on supporting the role of community health worker in health system development. So I would like to invite Professor Dr. Siyun Lui. The floor is yours.
Okay, thank you very much. Good afternoon, everyone. It's a great pleasure to join this meeting today. This morning's discussion was very thought-provoking. I see the different perspectives from low-income country, high-income country. We have different interests in this topic. I like the topic of this session is called strengthening the local health system to address the international migration of health workers. So I think strengthening local health system is the key to address this issue. I'm going to talk about some, I think because we understand now both the high-income countries and low-income countries, we all see we are in shortage of health workers. No country says we have surplus, we have enough health workers. So I think one of the key issues is to strengthen the capacity for the production of health workers, the medical education system. I mean, for both the high-income and low-income countries, we need to strengthen our capacity in producing more health workers. I'm going to talk a few points in this area. Number one is I think we need to try to strengthen the training of the local to train health workers suitable to the local context. For example, I mean, in many countries, my country, China, I mean, the current policy direction is to train the high-quality top physicians, etc. But I think in most remote rural areas, we need some lower level, not necessarily PhD, 10 years education system, but some middle level health workers might be useful for the local health system. So I think addressing the local health system context is important. The second point is another policy from China. I've mentioned in other meetings. You know, because in China, the international migration is not a big concern, but as I remember Philippine mentioned, the internal migration is a much bigger concern. The movement from the rural area to the urban area, from the another big area is from the primary care system to the hospital. So doctors are leaving the primary care system to the hospital. And from the least developed provinces to the most coastal areas. So I think the medical education system can do something to address this internal migration. So China started a medical education program in the year of 2010, 13 years ago. So we're trying to recruit locally from the rural background family, to recruit them into the medical university. But without tuition fee. Indeed, they don't need to pay for the medical education. But as a condition, they have to, after graduation, 5 years medical education, 3 years residence training, they need to go back to their hometown to work in the township health center, in the local primary healthcare system for 6 years. I mean, this is you have to sacrifice the freedom of free mobility, but I think it's a good system to strengthen the local health system for when in the situation when there is a severe shortage of health workers. So that kind of thing is I think another thing we can consider. And the last point I want to make is we talked about the international migration mostly from the lower middle income country to the high income countries. I mean, to me, I feel the medical education system, we can have some support from the high income countries, from the developed countries, to support the capacity in medical education to the lower income countries. So to help them I mean, and as a condition to recruiting their health workforce, they have the low-income country invested a lot money, financial resources, other resources in training these doctors. I mean, I think there is the condition can be the high income, the receiving countries can support somehow in the medical education. But of course, this needs some not only the international collaboration, but within the country, we need the collaboration between Ministry of Health and Ministry of Education, of course. I will stop here. Thank you very much.
I would like to start with thanking for this invitation. It's really very great. And I don't know, like previous sessions like this, whether we used to have, I mean, earlier years, whether we used to include trade unions or the global unions into the discussion. But this is really a great initiative that PMAC and also 3AH, I don't know how you say it, it's a bit long, have initiated this. I really appreciate that. Thank you very much for including a global union into this discussion. Our global union is a global union which represents the services sector workers throughout the world, and we call it healthcare and health and long-term care workers. I'm happy to be here with you to speak on all this challenging topic of this session. Why it is challenging is like smart investment. That is what the topic is. I don't know what is the clear outcome it would be after we finish the discussion, but investment is the core of anything that we would like to do. Now these days, when we talk about investment, investing in equipment, investing in institutions, which is like they have not been that much focused on the human part. But the investing on people, that is very important, especially when we talk about health. That is the core, that should be the core of our discussion, I believe. Now we are living in an interconnected world. So the migration is like unavoidable. And the transformative era of this era is the greatest cross-border mobility as well. And the mobility which is fueled by technologies and the technological advancement, changing pattern of the work, and the paradigm shift, we call it, when it comes to the world of work. It is not like before. There has been complete change in the world of work. And also, it is a deliberate response to the evolving nature of work with the expectation and the unprecedented opportunities, because people are like, they see that there is opportunity. We might be able to develop things back at home, but still people have that interest to see what is there in the neighbor. Let's look at our home arrangement. You have everything at home, but we would like to see the neighbor's house. Oh, what's the smell coming? What are they cooking today? Right? They must have cooked something special. So what is there outside? That has been a human nature. So that is also brings us to this mobility sense. And what I also see is the cross-border mobility is a strategic response to the skill shortage of the specific regions. But it is not only, like I would like to agree with Dr. Joanna, it's not like any part of the world or any area of the world or region is like shortage. Everywhere it is shortage. But we need to identify what shortage where. In some places, in the developing countries, the low or middle income countries, shortage everywhere. But when we talk about the high income countries, maybe shorten into certain segment, particular area of the health services, not everywhere, all the segment. So that's how it is also equally important for us to see on that part. The international migration of health workers is increasing, and if we see this pattern, they are getting complex as well. Complex, complicated, the impacts are critical and challenging. That is why I think it is a topic for us to have a discussion. The growing trend of intra-regional, south-south, and the north-south mobility, but especially when we talk about, like we are here in Asia and Pacific, most of the countries that our health force is like outgoing, outbound migration is there. So this would be like south to north migration is the biggest. Now, most of the developing countries are facing problem. I'm speaking here as a representative of a global union. So, I mean, we are the global union for services sector, as I already said. We also include in our structure health, community, and long-term care sectors. We have unions, professional organizations, the associations working with us and affiliated to us. While working with them and looking into the various interactions with them, the challenging facts are the workforce mobility, and we have conducted some campaigns how to deal with that. I would like to share some campaigns in empowering those workers and the professionals. This is what we use as a professional because we have a special department in Global Union. We call it Professional and Managers Department. So what we see there is it's not only in the health, even the other services sector. Normally, traditional unions would represent the rank and file workers. When is top is the management. But these professionals are in the middle, neither taken care by the workers' union, traditional trade union or workers' union, nor they are the part of the top management or decision making. And these people are really in a problem. They don't know whom to talk about. They have a real problem of collectivization. There's no collectivism, and these people are very much individualized. The reason is there is no collective force to represent them. So that is what we are trying to establish in that case. And also in terms of migration, also we are working with the organizations like in the Philippines and Nepal, these two unions that are affiliated to us, they are now discussing with Australian unions. They are trying to see the Australian unions can help them when these people go, especially in case of Nepal. These people go as a student. And these students are really not, some of the students now, they are just going after the +2 examination, which is like even undergraduate. And they go, some of them, they do some primary health education back home, but when they go back, they don't really work in the health establishment. They are not in the care. They are doing a cleaning job. So this is what we really need to see where we are. So there are challenges in many low or middle income countries with the outflow of the health professionals. It is not only due to the opportunities outside. We must think it is due to the career opportunities that they are lacking back home. There is what it comes, the investment. There is what we are asking, there has to be an investment in the health. So adequate staffing is also another problem. There are so many other issues, and we need to look into the investing in the training, skill, and upskilling. That is the core. We may not be able to stop migration. We may not be able to stop mobility, but we have to keep producing good people. That is the only option that we can meet that challenge. So investing in training and retraining is really important. The labor shortage and capacity constraint in the health and long-term care is another challenge area where we need more investment. The sufficient investment is critically important, but how it comes, that's very important part. If we see the budgets in various lower middle income countries, the allocation for defense is increasing. Allocation for education is going down. Allocation for health is also not very impressive. So these are the normal challenges, no? So that's what we have to really be able to work together in a collaborative format so that we can influence into this practice. And we are also we know one of the sustainable development goal 3, we target to achieve by 2030. The goal 3 talks about good health and the well-being for everyone. And at the same time, there is another 1-minute sign is there. There is another goal for us is goal 8, which talks about decent work. In the morning session also we heard about decent work, and Dr. Joanna also talked about that. Decent work is very important. Unless we have a decent work, we won't be able to really represent these people and get them back home, staying there. So this is what, in the morning, Dr. Reddy has also highlighted on one of the area that the competency is same everywhere. If competency is same everywhere in the health, so why not there is same standard in terms of the taking care of these health workers? So that is equally important for us. And there is also the ILO conventions. That's what we promote. The conventions on basically the core level standards, core level conventions about equality, no discrimination, freedom of association and collective bargaining. And now recently there has been 2 new conventions. Number 1 is the right to occupational health and safety. This is also equally important for us to promote for the workers. And at the same time, there is also another issue, that's new convention, ILO convention, that is 190, which talks about violence against harassment. This is also equally very important for the health workers. It's not only internal violence or harassment. It is about external, sometimes the third-party violence that we talk about. So that's also a big challenge for the health workers. Maybe there is no time for further to go, but I think it's a really very interesting discussion, I believe. And if there will be time again, maybe I'm here. Thank you very much. I need to stop. Thank you.
Thank you very much, Mr. Rajendra, for your impressive perspective that you mentioned about investment is very important for health workforce, especially in low middle income countries. So it's come to the last panelist, Ms.Diana, please.
Great, thanks so much, and good afternoon, everyone. It's really an honor to be here, and thank you so much for the invitation. I was asked to speak on U.S. domestic experience, and I do not work in U.S. domestic space. So I'm going to do my best sharing, I think, some interesting findings and how they potentially could be applied, I think, elsewhere. And specifically on the topic of brain gain and thinking about brain gain, which I think is really timely in this post-COVID-19 environment where we have this opportunity to reflect on the challenges that we saw operating in COVID, thinking about increasing mobility across the world, and how we also respond, right, as a global community in periods of pandemic and threats, and also, being able to reflect on those lessons learned for thinking about policy reforms, and especially as additional countries continue to think about policy reforms to enable foreign-based health workers to practice, thinking about also interventions and being able to address those key barriers for effective integration of those health workers. So I'm going to talk about 3 areas, and the first is regarding how you can prevent or ensure prevention of underutilization of health workers. The second is talking about enabling and allowing mobility, and then the third, touching upon that decent workspace, looking at wellness. The first area, so preventing underutilization. So first, just a little bit of context setting for the U.S. We have a very diverse health workforce in the U.S. Lots of data, and I pulled some figures. And I know that colleagues at the U.S. agency, the Human Resource Service Association, HRSA, which sits under the Health and Human Services Agency, has massive amounts of health workforce data for the U.S. state by state. But my understanding based on that data is that we have 2.8 million health workers who are immigrants. And that represents about 18% of the entire health workforce in the United States, so a sizable amount. And these workers fill many essential occupations in the health workforce, including doctors, dentists, pharmacists, and home aides. But I think another important context is that many people come to the U.S. not specifically seeking employment. They come to the U.S. and then they're looking for jobs, but they're not specifically coming to the U.S. for employment in the health sector. But this is where I think there are challenges about facing underutilization. So maybe not being able to you're trained internationally, but not being able to get a job in the profession that you were trained in internationally. And this could be challenges. And I understand that there could be upwards to about 300,000 individuals in the United States that are facing this underutilization challenge. An intervention which I found, which seems really innovative, is that there are welcome back centers created across various regions in the United States. They operate as a nonprofit, but essentially they serve as an information and resource center for people who have received formal education and training in a health field outside of the US, who live in the US, but would also like to enter a healthcare sector in the US. And so they provide orientation and counseling and support to foreign trained health workers, assisting those to develop career pathway plans, I think to navigate the probably very bureaucratic system in the US of licensure, looking at ways in which they can obtain appropriate professional credentials and licensures, but also exploring other educational opportunities and programs and job opportunities. So essentially setting up these resources to provide support to individuals who are looking for employment in the US. So I thought that that was a really innovative kind of intervention, but one to really to address this barrier, which I think is really important to think about as like policies and interventions to prevent that underutilization, especially in a context where we have 10 million health worker shortage. We want all individuals who have professional training to be practicing. So in the second area, allowing mobility. And another US context, right, we have state-based licensure. So you have to be licensed to practice in the individual state of which you reside. And also employment in the US, most of health is provided in the private sector in the United States. So most of the employment is private sector. It's not provided by the state or the government. But in the US, which has historically been a policy and intervention that has existed prior to COVID, is we have the Nurse Compact, which was created to allow nurses to travel and work across multiple states, as opposed to having a single state licensure. And this really allowed states that maybe had health worker gaps to come together to have this compact to allow nurses to be able to travel back and forth to meet those needs. And more rapid mobility and sharing of health worker resources, essentially. And again, this historically was only set up across multiple states, but during COVID, because of significant health worker shortages and demands, there was an executive order at the federal level that basically made it across all states. So very rapidly, nurses were able to travel across all 50 states. And this led to extreme flexibility and surge capacity. And in fact, they saw 35% growth of nurses wanting to work in this traveling capacity. So it really led to high demand for traveling nurses. And also it led to actually high demand of hourly rates. So you actually saw nurses that were traveling nurses making upwards to, I think, of like $150 an hour. So high demand, I think, in being a traveling nurse to meet. Interestingly, since COVID ended, the executive order expired. And so this intervention is no longer in practice, and it's gone back to its pre-COVID kind of what was allowed. But it's raised a lot of policy discussions around should it be something that should be allowable all the time. And I think that it's raised debates with advocacy organizations and unions around kind of diminishing bargaining power across nurses and at the state level and different wage competition issues. But I do think that the nursing compact is seen as a success in the United States, and it can also, I think, I think of United States as an island. Each state essentially could be like a mini country in some ways. But I think something, food for thought about allowing a compact, even at a regional level, to allow kind of flexibility of health workers across countries. And also, how that could help build capacity in the next pandemic threat. So you have that capacity in place and that experience of working across countries. And I know I have 5 minutes. The last area I wanted to touch upon was wellness. And of course, COVID showcased, the needs for health workers and that relationship between work and well-being. And in the U.S., our Surgeon General over the past 2 years set up an advisory committee on how to really help address health worker burnout and to prevent moral injury amongst health workers. And released this framework that, if you could put the slide up, which is being applied nationwide in terms of thinking around how to really address and put more focus, I think, on the individual of a health worker in addressing mental health and well-being. Survey data has showed in the U.S. that 76% of health workers report at least one symptom of a mental health condition, and 84% of health workers claim that their kind of mental health status is impacted by their workplace condition. So I really like this framework, which has kind of 5 arms. The first including, importantly, protection from harm, which includes things as physical and psychological safety, ensuring that the measures are in place, that health workers have enough adequate rest between different shifts. The second being connection and community, interventions for social support, and more focus on belonging and teamwork in the workplace. Work-life harmony, which includes interventions around autonomy, but also flexibility. And in things as it relates to work-life balance and ensuring that individuals have paid time leave or other kind of benefits and social protections. The fourth here is mattering at work, which includes topics as it relates to adequate remuneration, kind of engaging health worker voices in decision making. I really like this focus on building a culture of gratitude and recognition. And then the last arm, which is opportunity for growth. So having opportunities for professional development, mentoring, career advancement, and ensuring feedback. So this is a framework that has just been put in place recently, but I think just also underscores kind of the importance that our U.S. policy is placing on really addressing this topic, which became such a critical issue in all over the news, of course, during COVID. And I will note, linking to our international work, our current Biden administration, our current president, has launched a global health workforce initiative. It was launched in May 2022 at the White House. But these are also principles that we've integrated into that initiative, really just underscoring the recognition of that we need, I think, in the health worker agenda space, more focus on decent work and wellness and protections. So with that, those are just some reflections. Again, those 3 areas that I think are food for thought around interventions to prevent that underutilization, how to really allow and enable better mobility, and then and addressing wellness issues. So thanks so much.